Here's another video that has been in the works for a very long time, and I don't know how I forgot to record this video in bits and parts. But anyways, better late than never. Let's do bacterial meningitis. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at bacterial meningitis. If you haven't yet subscribed to the channel, please hit the subscribe button. Hit the bell notification icon so you never miss on such amazing content every time I post. Grab a piece of paper and let's go. So this would be in the background of perhaps a student, a jail cell member, or anyone gets this short illness. All of a sudden they deteriorate very quickly and they die. Meningitis is a very deadly thing, and often patients are actually going to die when they contract this and it's not picked up early enough, and if they don't receive the adequate treatment. And one of the saddest things is that people will come to the hospital and you as a clinician will have a suspicion that they have meningitis. You would want to order for a lumbar puncture. You offer that option to the relatives. They have this sort of aversion from a lumbar puncture because of the different myths that they've heard out there. And you give your patient empirical treatment, but you may not be targeting what may be causing the meningitis. Moreover, a lot of strains of bugs that are going around these days are resistant to most of these antibiotics that we're giving. So patients begin to deteriorate. When eventually they see that the patient is about to die, they will agree to the lumbar puncture. You do the lumbar puncture, but it'll be too late for this patient. If this patient dies, the relatives are obviously going to say the lumbar puncture is what finished off this patient. But what people need to understand is that the lumbar puncture itself is not a deadly procedure. It actually helps us make a diagnosis of meningitis. So remember that the brain is going to be covered in these membranes, which are known as meninges. So from the outside coming inside, you have the dura mater, which is adherent to the bone, the arachnoid matter, which is just underneath, and the pia mater, which is adherent to the brain. In between the bone and the brain and these membranes are potential spaces. Between the bone and the dura mater, you have the epidural space. Between the dura mater and the arachnoid matter, you have the subdural space. Between the arachnoid matter and the pia mater, you have the subarachnoid space. Remember that CSF is going to be present in the subarachnoid space. And remember that the CNS is a closed cavity consisting of brain tissue, consists of blood vessels and blood. It also consists of the CSF, which is in constant volume, such that if there's an increase in one of these components, it will be at the expense of the other two. So if there's an increase in the CSF production, it means that the brain tissue is going to be compressed. If the brain tissue is swelling up, it means that the blood vessels are going to be compressed. Remember that infections can also affect the CNS, though not so common, especially in immunocompetent individuals, because of the blood-brain barrier, which is sort of like the barricade or the police at a club, the security guards at a club for you to enter into the VIP section. So it's like really, really heavily guarded off. So if these infections actually get hold of these meninges, they can actually result in inflammation of the meninges. Remember, anything that ends in itis means inflammation. Meningitis is inflammation of the meninges. Remember that your meninges, your arachnoid matter, and your pia mater are collectively referred to as the leptomeninges. So when you talk about bacterial meningitis, remember it's one of the most common forms of suppurative infection. And if it's not treated, most patients, if not all, will die. So the organisms can actually reach the meninges by one of three ways. They could reach the meninges commonly through a droplet infection through the upper airway. So someone will even have these respiratory symptoms. Eventually it will spread to the meninges. And remember that Neisseria meningitidis could be sometimes part of the normal flora in that area in the respiratory tract. And you can actually pass it on through these droplets, through sneezing, talking, laughing, so on and so forth. It could be sometimes through direct extension from a contiguous area, from an adjacent area, for example, from the ear, the otitis media. Remember that between the middle ear and the temporal bone, there's a very thin plate of bone which is known as the tegmen tympani. If there's an infection in the middle ear, it can spread upwards and going to affect the meninges. Sometimes it could be coming from the nasopharynx, from a sinusitis. Sometimes it could be a cranial injury or even a congenital meningeal defect. Sometimes it could spread via the bloodstream, hematogenously. It comes from somewhere else. For example, someone has an infection elsewhere in the body and it spreads to the meninges and causes a meningitis. More or less, this would be part of a sepsis. Remember that immunocompromised patients are going to be at greater risk. This is very common for all the infections that we know of, and these are going to be susceptible to unusual organisms. And with bacterial meningitis, there's a higher risk of developing cerebral edema. You will be able to even see these features of edema on your CT scan. What are some of the things that could cause bacterial meningitis? So we can group them according to the age. The infants, or those that are less than 1 year, things that are common include E. coli, group B streptococcus, Listeria monocytogenes. Those are the most commonest organisms. Those that are between the age of 1 to 6, the young children and the toddlers, Haemophilus influenza, Meningococcus, which is also referred to as Neisseria meningitidis. These are going to be accounting for more than half of the cases. In adolescents and adults, you have Meningococcus and Pneumococcus being quite common. Then in the immunocompromised and those patients that have cancer, Listeria, Staphylococcus, Pseudomonas aeruginosa become quite common. Some important causes that I want you to keep in mind: strep pneumoniae, 30 to 50%, Neisseria meningitidis, about 10 to 35%, Staphylococci, about 5 to 15%. These numbers may vary depending on where you practice your medicine from. The gram-negative bacilli, about 1 to 10%, Listeria species, about 5%, Streptococci, about 5%, and Haemophilus influenza, about 1 to 3%. This has become quite rare because we now institute the immunization against Haemophilus influenza, especially the type B. Some risk factors that can put someone at risk of developing meningitis include age extremities. So those that are above the age of 60 and those that are below the age of 5 because of immunosuppression in these areas. The older you get, your immune system also is a bit suppressed. The younger you are, your immune system hasn't yet learned to fight off most of these pathogens. It's also seen in children with diabetes mellitus, those with renal and adrenal insufficiency, those with hypoparathyroidism, or those with cystic fibrosis. Any sort of immunosuppression would predispose them to actually develop meningitis. And remember that for inflammation to happen, you need your immune system actually to be working. So someone who's severely immunosuppressed, they may actually develop meningitis minus having those meningeal signs. They may not have the fever, they may not have the meningeal inflammation and those typical meningeal signs. So you need to develop a high index of suspicion because those meningeal signs are as a result of meningeal inflammation and meningeal irritation. But you don't have this because this person doesn't have an immune system to react to this. It's seen in crowding or crowded places, for example, military recruits, in college dorm residents. These ones, they increase risk of Neisseria meningitidis or meningococcal meningitis. Then for those patients that have undergone splenectomy, even those with sickle cell, remember these are particularly susceptible to encapsulated organisms. Those that are taking alcohol and those that are cirrhotic patients, remember there are many different causes of fever and seizures in these patients that can actually mimic meningitis and actually can have a very difficult time making a diagnosis. Diabetes also, because it does cause some sort of immunosuppression. What are some of the clinical features? Remember, if it's with Neisseria meningitidis, it has a quite short incubation period, so about 1 to 10 days with an average of about 2 to 4 days. So most patients, if not 90% of the patients that get this type of meningitis, bacterial meningitis, will have 3 of these signs. So they'll have neck stiffness, which is also referred to as nuchorigidity. Remember, this is because there's some meningeal irritation. If your patient is conscious, you can just simply ask them to put their chin on their chest. If they can do this, then most likely there is no meningeal irritation. Or if they're unconscious, or if you want to do it yourself, you ask them to relax and then you passively attempt to flex their head, to bring their chin to their chest. You'll be able to see that you'll be limited by this and they'll be in pain. But remember, this sign is not really reliable, especially in those patients that have cervical pathologies. It's not reliable in old patients. It's not reliable in very young patients. They may also have a headache. They may also have a fever. So that's our classic triad that we see in meningitis. They may have altered mental state in about 75% of the cases. It may range from drowsiness, lethargy to coma, and even loss of consciousness. They may have photophobia, where they are avoiding these lights. They may have nausea. They may have projectile vomiting, which is because of the increase in intracranial pressure. And remember, if you purely have a meningitis on its own, it's very rare that you're going to have seizures. Seizures will often occur when someone also has an underlying encephalitis. So they will more or less have a meningoencephalitis. So remember that sometimes seizures can be part of an initial presentation of a bacterial meningitis with an underlying encephalitis, or sometimes it could be during the course of the illness in about 20 to 40% of the patients. Those patients that actually have an acute infection may present with an intense malaise, fever, rigors, a severe headache, photophobia, and vomiting, which may be projectile, that often develops within hours to minutes. And remember that in meningococcal meningitis, it's sudden onset. They have this severe course. These patients develop this characteristic type of rash. So they'll have this erythematous maculopapular rash that can sometimes cover their entire body. It's common on the trunk. It can even cover the limbs. It may sometimes become petechiae. It may be purpura. It may be bullous lesions. Whenever you see this and this patient is in shock, then you're thinking that possibly this patient could have vascular collapse. Possibly they could have a complication that is known as Waterhouse-Friderichsen syndrome. So you look for these petechiae that you may find on the trunk. You may see them on the lower extremities. You may see them in the mucous membranes, even in the conjunctiva. You may see them on the palms and even the soles of the feet. So some of these symptoms that are not seen in infants, the classic symptoms that are not seen in infants, you may have a prodrome of an upper respiratory tract infection, very common with viral and even bacterial meningitis. Headache, it's very difficult for an infant to complain of a headache. Mucorigidity, you don't see this especially in the child that's less than 1 year, and then even in patients that have altered mental state. Fever and chills, photophobia, vomiting, you may sometimes see it. Seizures are quite common in children, not so common in adults. So 30 to 40% occur in children, 20 to 30% occur in adults. You may sometimes get focal neurologic symptoms like focal seizures. There may sometimes be an alteration in the sensorium. So sometimes in adults, confusion may be the only presenting symptom. In terms of the meningeal signs, I want you to be aware of 3 important ones. I've already talked about one of them. So I've talked about neck stiffness or mucorigidity, where you attempt to passively flex the head, and you will see that there is some limitation that is there. So there are 2 important signs. So I'm going to skip this and I'm going to show you the picture first, then I'll come back to it. So there are 2 important signs. There's what is known as the Brzezinski sign, and there's what is known as the Kernig's sign. And this is how I remember it. Kernig's sort of sounds like knee, Kernig. So it means that you're doing something with the knee. Then, of course, Brzezinski is the other one. So with your patient is going to be lying flat and they'll be relaxed. They'll be lying flat, supine in bed. So with the Kernig sign, first of all, you're going to flex the hip. So you bend the hip in that manner. With also the knee flexed, and you attempt to straighten out the knee. So you attempt to extend the knee. So you're going to straighten out this leg. You'll see that there will be limitation to this. This child will come up like that. The head will come up, or they'll be in pain. So that's what is referred to as a positive Kernig's sign. Remember, these signs are not so reliable if your patient is unconscious. And then Brzezinski sign, you simply ask them again to lie supine in bed, and then you simply passively flex the neck like that. You bend the head in that direction, like bringing the chin towards the chest, and you see that the knees will come up in that fashion. So this is what we refer to as a positive Brzezinski sign. So that's our Kernig sign, which I've already explained. That's our Brzezinski sign. Sometimes you may have some cranial nerve abnormalities. It may affect the facial nerve. It may affect the oculomotor nerve, and sometimes it may even cause deafness. I remember when I was in 5th year, I saw a woman that actually had cryptococcal meningitis, and she actually went blind. And the blindness is permanent. So remember, like I said, these signs are not so elicitable, if there's such a word. You can elicit them in infants, not so reliable in old patients, even in patients in coma. So the sensitivity of the Kernig's and the Brzezinski sign are quite uncertain. And both of them actually absent even in patients that are immunosuppressed, in patients that are very young, and those that are very old, and those that have depressed mental status. So even with high prevalence of cervical spine disease, in older individuals, they may actually give you a false positive. You may think that someone has a positive Brzezinski sign, meanwhile they just have, or positive mucorigidity, meanwhile they just have a cervical spine disease. So what are some of the clinical clues that may point you towards specific diseases? If you have a particular rash, you're thinking this is a meningococcal infection. If there's a skull fracture, ear disease, or even a congenital lesion, you're thinking this is a pneumococcal infection. If it's immunocompromised, you're thinking maybe these are opportunistic infections. If there's a rash or pleuritic pain, you're thinking this is an enterovirus infection. If they're recently traveled, you're thinking, could this be malaria? If they are presenting with a history of them working in drains and sewers, maybe with polluted water or recreational swimming, and they present to you with features like muscle aches, conjunctivitis, as well as jaundice, maybe you're thinking this is leptospirosis. What investigations are we going to do? First of all, you're going to do a diagnostic investigation. You want to do a lumbar puncture. But remember, before you do your lumbar puncture, ensure that the patient does not have any contraindications to lumbar puncture. Remember that the contraindications to lumbar puncture include patients that are hemodynamically unstable, so meaning patients that have either very high BPs or very low BPs. First, you want to stabilize those things before you're doing your lumbar puncture. Patients that are in respiratory distress, you don't want to do a lumbar puncture. So those three things. Of course, if your patient refuses, you don't want to do the lumbar puncture. Number 5, contraindication if your patient has a bleeding disorder, or if your patient has a severe thrombocytopenia, you don't want to do a lumbar puncture. You want to address that first. If the patient has an infection at the site of the lumbar puncture, you don't want to do your lumbar puncture. Those are some of the contraindications. If they have a mass with increased intracranial pressure, you don't want to do your lumbar puncture because you may cause your brain to herniate. So you should do this if there's no clinical suspicion of a mass, and if the mass is actually seen on, or suspected rather, they have anisocoria, there are features of increased intracranial pressure, decreased level of consciousness, projectile vomiting. First, get a CT scan for this patient, because if you do your lumbar puncture, you may actually put this patient off coning of the cerebellar tonsils. The brain may begin to herniate, your patient may die. So when you do your lumbar puncture, you're going to send your CSF for microscopy culture sensitivity. You're going to be checking for stains like you do a gram stain for checking for positive gram-positive intracellular diplococci. That's usually suggestive of pneumococcus. If you get your gram-negative cocci, this is usually suggestive of meningeal cocci. If you get gram-negative coccobacilli, this is usually suggestive of Haemophilus influenza. Even when they give you this on the exam, they'll give you this typical description on the exam. Zn stain for TB. You can also send it for GeneXpert. You can send it also for India Ink. So you're going to send the CSF for microscopy culture sensitivity. You're going to send the CSF for biochemistry, where they're going to check for certain parameters that will help us now tell whether this is bacterial meningitis, viral, TB, or fungal. You can also send it for CSF PCR to check for certain other viruses. Do an RPR, VDRL, or TPHA for syphilis. Do an RDT for malaria. You can also order for serum cryptococcal antigen, especially if the baseline is known, but this is less diagnostic than actually taking the CSF and staining it with the India ink and seeing the cryptococcal. I'll do a separate video on cryptococcal meningitis later on. Then you want to also do a blood culture. Remember, 50% of the patients that have meningitis because of this respiratory pathogens like Haemophilus influenza, strep pneumoniae, and even Neisseria meningitidis, you can actually get a positive blood culture in about 50% of them. You also want to get swabs from the nasopharynx, respiratory secretions, urine, and skin lesions if present. You can also do your latex agglutination or counter-immunoelectrophoresis for the blood, urine, and CSF for specific bacterial antigens, though this is not routinely done. Some supportive investigations include a full blood count with a differential. Of course, you're going to see a high white blood cell count, and depending on if it's bacteria, you're going to see a lot of neutrophils increasing. Then you want to do your serum glucose. This is going to be used as a baseline because your CSF glucose is largely dependent on the serum glucose. I will explain this very shortly in the next slide when we look at the CSF biochemistry profile. Then you also want to get your serum electrolytes because remember, there may be some dehydration, there may be syndrome of inappropriate ADH secretion. You want to do your urine electrolytes if you're suspecting SIADH. You want to get a chest x-ray and a skull x-ray whenever necessary if you're suspecting that there's maybe, for example, a basal skull fracture. How will you know this? This patient will be leaking CSF from their nose. They'll be leaking CSF from the ears, for example. If you put this CSF on a filter paper to form a halo around, so that's what will hint you that this is CSF and it's not really blood. Then get a CT scan, like I said, an MRI to rule out any space-occupying lesions, which may also show you some sort of hydrocephalus. There may be some cerebral edema that may be there. Sometimes your CT scan may not be so helpful, especially in infectious processes. Then you want to do your BUN and creatinine as well as liver profiles to assess the organ functioning and also to help you adjust the antibiotics that you put your patients on. Do a coagulation profile and check the platelets, especially in patients that are chronic alcoholics, those that have liver disease, or if you're suspecting DIC. So these patients may actually even require platelets or FFP before you do your lumbar puncture. Now this is the profile for the CSF biochemistry, and I want you to understand this. I don't want you to memorize this. I just want you to understand it because it makes sense. So the parameters that we look at are the opening pressure, which sometimes we don't really do because we don't have the equipment to do this, the appearance, the cell count, the cell type, the glucose, the protein, and the lactate dehydrogenase. So the normal opening pressure is 50 to 250 millimeters of mercury. This is supposed to be mercury, not water, and 5 to 15 centimeters of water. So CSF should be crystal clear. It's very clear, actually even much more clear, probably much more clear than your tap water. You should have less than 10 red blood cells per high power field and less than 5 white blood cells per high power field. There shouldn't be any predominant cell type that you have there. Your glucose must be 2/3 to 1/2 of your blood glucose, which is why I told you it's very important to actually get your blood glucose. Then the proteins are about 0.2 to 0.4 grams per liter. Then lactate dehydrogenase is less than 3.5. Now, if you have a bacteria inside the CSF, remember that bacteria are going to be multiplying. They need glucose to multiply. They're going to attract the inflammatory cells to come to that area. They're going to cause a lot of proteins that are made from the immune system to come to that area. So already all these things accumulating in the CSF will increase the pressure. So you expect the pressure to be normal or increased. Because of the reactions that are happening, a lot of these inflammatory cells, even the color of the CSF would be expected to change. So it's going to be turbid. And remember, because it's a bacterial infection, you expect a lot of those non-specific cells, those neutrophils to be there. So you're going to see several thousands, about 1,000 to 5,000 polymorphs. And most of these will be granulocytes. And because these bacteria are actively multiplying in the CSF, they're going to be using up the glucose in the CSF, so you expect the glucose to be low, less than 1/2 of the blood glucose. Then protein is going to be high because there are a lot of antibodies being made, there are a lot of complement proteins, and all these exudate that is forming. So you expect the protein content to increase greater than 0.5 to 2 grams per liter. Lactate dehydrogenase is also another protein. You expect it to increase because there is some sort of inflammation happening, greater than 3.5 millimoles per liter. Then in terms of viral meningitis, remember viruses are they're not really living things. Again, they're not non-living things, they're like in the middle. Some people don't actually consider them as living things. So they won't cause so much change in the CSF. It will almost be similar to what is like a normal profile. So the opening pressure will be normal or mildly increased. The CSF will be clear. It won't be crystal clear, but it will be clear. When you look at viruses tend to attract lymphocytes. So you're going to see several hundreds, about 10 to 2,000 lymphocytes. Those will be the predominant cells, and the blood glucose will be normal. Why? Because viruses don't need glucose to replicate. They don't need glucose to multiply. So you'd expect the CSF glucose to be normal. Remember that a decrease in CSF glucose is what is referred to as hypoglycemia. Then the proteins are going to be normal because they're not stimulating this sort of significant immune response as compared to the bacterial meningitis. And then, of course, your lactate dehydrogenase will be less than 3.5. In terms of TB again is like mycobacterium. It's like a bacteria, but rather causing a chronic type of infection or chronic type of inflammation. So there will be normal or increased opening pressure. There's a characteristic cobweb appearance of the CSF. You get a lot of lymphocytes and monocytes, about 50 to 5,000. Because it's using up glucose as well, you expect the glucose to decrease less than 1/2 of blood glucose. Then the protein is going to increase more than 0.5 to 3 grams per liter. The proteins could actually be quite high, especially in TB. Lactate dehydrogenase is above 3.5. Fungal is also another chronic thing. So here, the fungal meningitis, especially with cryptococcal meningitis, you actually have quite high pressures, such that when you do a lumbar puncture, it's not only diagnostic, but it's also therapeutic for patients that have cryptococcal meningitis. It may be clear or cloudy. You get a lot of these chronic cells, so several hundreds of mononuclear cells. 10 to 500 cells of lymphocytes and monocytes. Again, this fungus is using up the glucose, so you expect the glucose to decrease, and you expect the proteins to also increase, greater than 0.5 to 3 grams per deciliter, and the lactate dehydrogenase greater than 3.5. So you should understand this table very well, and if they bring this on your exams or even in real life, you should be able now to tell that, okay, this looks like a typical bacterial meningitis, this looks like a typical viral meningitis. Of course, we'll cover the other types of meningitis in subsequent videos. Now, how do we manage these patients? So there's general and supportive management. There's also medical management. So what do we do for your patients? You resuscitate them, do your ABCs, give them oxygen, make sure that the saturation is above 92%. We want to treat them. If they have increased intracranial pressure, you want to treat them. So what can you do for your patient? Elevate the head end of the bed by about 30 to 45 degrees. You want to intubate your patient if need be and hyperventilate them until your partial pressure of carbon dioxide, arterial partial pressure of carbon dioxide is lowered to 25 to 30. Remember, this is the quickest way to actually drop the intracranial pressure. You may put them on mannitol, that's 20% mannitol, IV 5 mils per kg over 30 minutes, and a corticosteroid 4 hourly, though this has not been shown to be quite effective even in the management of intracranial pressure. You want to put them on steroids. Remember, steroids are, even though you have an infection and you know that steroids are going to lower your immune system, but remember that some of these clinical features that we're seeing because of meningitis are because of your own immune system overreacting to this infection. So you want to actually hush down the immune system to give the antibiotics chance to work. And so these steroids could actually be started before you actually start the antibiotics. And they have actually seen that patients that actually have received steroids prior to antibiotics or with antibiotic therapy have decreased chances of death. They have decreased chances of neurologic complications. So it's actually quite advantageous, especially in children with meningitis that is going to be caused by Haemophilus influenza, that's going to be caused by pneumoniae, strep pneumoniae. So you can give them dexamethasone, 10 milligrams IV, 15 to 20 minutes before the first dose of antibiotics, and then 4 milligrams IV 4 times a day for the first 4 days. For the patients that have meningococcal meningitis, you isolate them, and you should also put them on some thromboembolism prophylaxis because they may be bedridden for some time. So a low dose, low molecular weight heparin like a Clexane or enoxaparin. Now, what antibiotics are we going to go for? So initially, your antibiotics must be broad spectrum, covering whatever you're thinking could possibly be causing this type of meningitis. Then once you get a culture and sensitivity report, you can actually narrow your antibiotics to what is being used. And remember that the antibiotics that you're giving strictly are intravenous antibiotics, and you give them at quite higher doses. So if it's an adult that doesn't have any underlying disease, you can give them your ceftriaxone 2 gram IV twice a day, together with ampicillin 2 gram IV 4 times a day for 2 weeks. Then crystalline penicillin 3 to 4 million international units, IV every 4 hours, together with chloramphenicol, 1 gram IV QID. These ones can actually be used, especially chloramphenicol can actually be used for those that have Neisseria meningitis. So these can be alternative antibiotics. Ampicillin could also be alternatively be given 100 to 200 milligrams per kg IV 4 times a day. Then if it's a patient that has an ENT infection or a head injury, ceftriaxone 2 gram twice a day with vancomycin 1 gram IV twice a day. Of course, this vancomycin may be very difficult to get from your pharmacy if you don't have a culture. You also want to treat the underlying cause. If it's a hospital-acquired infection, cover them on ceftriaxone as well as vancomycin plus a gentamicin. If they're immunodeficient, cover them on a ceftriaxone, a vancomycin, and ampicillin. These may sometimes even be quite difficult to get from your pharmacy, minus actually you having a culture result, unless if it's an infectious disease specialist that prescribes these. But of course, if you consult an infectious disease specialist and they think that the patient actually needs these antibiotics, then they may get them minus having the culture. Then your intravenous antibiotics should be put in the first 72 hours. For as long as the patient is unconscious, don't change them to oral. Keep them on IV. Then the treatment is going to be continued for at least 1 week after the fever subsides and the CSF returns back to normal. Then if it's Neisseria meningitis, it tends to respond quite well to ceftriaxone. It tends to respond to cefotaxime. It can actually cover it, but penicillin G is actually quite the drug of choice, your crystalline penicillin. If it's a pneumococcal meningitis, usually these respond to cephalosporins together with vancomycin. If it's a Haemophilus influenza, cephalosporins tend to work quite well. Chloramphenicol can be used as an alternative for those that cannot afford ceftriaxone. If you're suspecting TB, put them on TB medication. Rifampicin, isoniazid, pyrazinamide. Remember, ethambutol in some cases was avoided, but now we still use it in the regimen because the risks of you developing optic neuritis are very small. Even from the clinical trials, very few patients actually have developed it. Then you continue them on an adjuvant corticosteroid like a prednisolone, 60 milligrams for 3 weeks. Then you taper it off. Again, here's, to hammer it home, unknown pathogenic bacteria, cefotaxime, alternatives, benzopenicillin and chloramphenicol. Meningeal coccus, you have benzopenicillins, cefotaxime. Pneumococcus, you have cefotaxime or penicillins as an alternative. Haemophilus, you have cefotaxime, chloramphenicol as an alternative. Again here, this one here even gives you according to the ages and the preferred first choice and the second choice, and for those that have severe penicillin allergies. So please pause the video, get a screenshot of this, and remember that these do tend to change after some time because the sensitivity patterns and the culture patterns actually quite vary according to the different places. Even in our country here, they vary according to different hospitals. There are certain organisms that tend to linger around certain hospitals that are resistant to certain drugs. Complications include brain edema, hydrocephalus, brain abscesses, septic vein thrombosis, hearing impairment, and fulminant meningosepsis, which is the so-called Waterhouse-Friderichsen syndrome that I talked about, where someone has a meningococcemia that's going to be causing this hemorrhage that is happening and affecting the adrenal gland. So this person goes into vascular collapse. There's this multiple organ failure. So your patients will be hypotensive, they'll be in shock, they'll have this purpura and even this petechia in the mucosa and even their skin, and then they may even actually have DIC. So this is a quite deadly thing. You want to isolate your patients and treat them promptly. Chemoprophylaxis in those that have Neisseria meningitidis, all the close contacts must be given chemoprophylaxis, either rifampicin 600 milligrams twice a day for 2 days in adults and 10 milligram per kg twice a day for children that are above 1 year. Ciprofloxacin 750 milligrams as a start dose could be given. Remember, we avoid this in children. You also want to vaccinate patients with the Men-C vaccine, the meningococcal C conjugated vaccine, and this is part of many vaccine immunization programs, and it's actually often offered to the contacts. A combined A and C vaccine can actually be given in endemic areas like in Africa and in Asia, and a quadrivalent ACWY vaccine is actually given in some specific areas. So there is no vaccine for Group B. A polyvalent pneumococcal vaccine as well as Haemophilus influenza vaccine actually given routinely in childhood. I did a video on immunizations and vaccinations that you can check out in the pediatric playlist. I really hope you enjoyed this video on bacterial meningitis. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.